Hi everyone, it's Sue again, and I'm going to just record here a short discussion that focuses on acute kidney injury. And it's really important that we understand there are three main categorizations of acute kidney injury. Pre-renal, so something happens in the circulatory system or in other systems that, that occurs prior to that kidney damage happening. Something happens within the kidneys themselves, intrarenal causes, and then post-renal is where something happens beyond. So let's start with pre-renal. And typically what we're looking at in pre-renal are many different conditions that affect the amount of blood volume, circulating blood volume you have. A good rule of thumb is that blood pressure less than 60 for 20 minutes leads to acute kidney injury, often permanent kidney injury. So recognizing that as your blood pressure drops and the amount of perfusion, blood perfusion through your kidneys then subsequently drops, you end up with this acute kidney injury. So what kinds of things can cause that decrease in the amount of blood that's flowing to your kidney? For sure, hypovolemia, right? And often we're looking at things like dehydration. You could have a massive hemorrhage. You could have huge GI losses that lead to dehydration, things like vomiting and diarrhea. Excessive diuresis, if we're heavily diuresing a patient and we actually bring them to a point of dehydration, or patients who develop things like diabetes insipidus or conditions like that that cause them to, or even DKA, diabetic ketoacidosis, where they are passing large quantities of urine. In burns, where we have those massive fluid shifts and we lose all kinds of fluid, not just outside of the body, but outside of easy access. So it leaves the intravascular space so that there is a very little circulating volume. When we look at decreased cardiac output, remember we talked about that before. So we may have enough blood that could circulate, but our heart is not able to pump it around. So we're not able to get it to the kidneys to then move through that perfusion process. So things that could cause that decreased cardiac output are often heart failure, myocardial infarction, sometimes something like a pericardial tamponade, so again, a cardiac condition, or pulmonary edema. Sometimes if we give antihypertensive drugs, that can cause it because, again, instead of just bringing their blood pressure down to a reasonable rate, we can actually bring it down too low and we're not perfusing the kidneys adequately. All kinds of shocks, including maybe even septic shock, is another good example. When we're talking about intrarenal kidney injuries, we're talking about things like nephrotic injury, so an actual injury within the kidney. Some kinds of drugs, medications that we give can cause acute kidney injury. So a really good example is a category of antibiotics called aminoglycosides. Gentamicin and amikacin are really common drugs, and we are very careful in dosing those with people who might have kidney injury or kidney an alteration in kidney function. When we give those radiocontrast injections for patients who are going to have things like an IVP. When we have a blood transfusion reaction, a hemolytic reaction, it causes significant injury as those blood cells are being disrupted and burst, those red blood cells. And that causes injury within the kidney. If we have injuries, like abdominal injuries that lead to actual trauma to the kidney, crush injury, allergies can lead to that kind of injury when you have a profound allergy to a medication. And sometimes if you take high doses of non-steroidal anti-inflammatory drugs, that can, again, cause that injury. So we need to really be careful, again, when we're giving those non-steroidal anti-inflammatory drugs, that we check kidney function, and that's something that's often missed. And then the final thing is post-renal, so beyond the kidney. So imagine, we talked about this in the last lecture, I think, about that BPH. You've got that prostate that is very enlarged. You're not able to pass your urine. That urine backs up, and at first the kidney or the bladder can hold some of that urine, but you move beyond the bladder being able to hold it. It continues to back up, and you've got that sort of flooding within the kidneys that can cause damage. Different kinds of cancers that are beyond the kidney. Those calculi, remember, it's sort of like the BPH. Again, something that's blocking urine flow beyond the kidneys that then causes that urine to not be able to be excreted down through the ureters. Sometimes when you have a neuromuscular disorder, particularly severing of your spinal cord or paralysis, you can have a neuromuscular loop that can lead again to a kidney dysfunction or a bladder dysfunction, and that bladder dysfunction can lead to a hyperreflexive situation that can cause your kidney to have damage as well. So let's look at sort of an overview of this when we're looking at acute kidney injury versus chronic kidney disease. And we're going to talk about chronic kidney disease shortly. But the onset for acute kidney injury is sudden. This is something that happens suddenly as compared to over time. When we have chronic kidney disease, it happens over time. The most common cause is acute tubular necrosis versus diabetic neuropathy is the most common cause for chronic kidney disease. Diagnostic criteria are really important when we're looking at the two different characteristics. Acute reduction in urine output is really important when we consider diagnostic criteria for acute injury, right? So less than, remember I think we've talked about it in this course, if not, 60 mils of urine per hour is the normal, typical amount of urine that a healthy person processes, but what we would consider adequate is 50% of that. So that's why we always remember 30 cc's per hour. But when we're looking at acute kidney injury, we see a sudden acute reduction in that urine output. We also see an elevation in creatinine as well. When we're looking at chronic kidney disease, we're looking at our glomerular filtration rate, less than 60 mils per minute for greater than 3 months. We're looking at kidney damage for greater than 3 months or both. Okay, so when and again, keeping in mind that entire process for chronic kidney disease, our hallmark is 3 months, a 3-month period. Acute kidney injury is potentially reversible. Chronic kidney disease is not reversible and it is considered progressive. Mortality is high in both types of patients. So acute kidney injury, we have almost 60% mortality, which is really shocking. When we look at chronic kidney disease, up to 25% of patients can be on dialysis. So extremely debilitating and really incredibly difficult for patients to find ways to manage both the risk to life, but also their the consequences to their lifestyle. Primary cause of death, again, with acute kidney injury is infection, and with chronic kidney disease, because we have that high blood pressure and other sequelae or consequences to it, it tends to be cardiovascular disease. And look at here. In this picture, what we actually see is acute tubular necrosis. So if you compare this picture to what you would expect in a beautiful kidney, where you have that nice red kidney and they should be sort of that bean shape look, here what we see are very, very pale kidneys because we don't have that blood perfusion. The renal tubules are necrotic. We're not having blood flow through those renal tubules. We're not having good perfusion through our kidneys, so we lose that beautiful pink color, and they're actually very swollen. You see, they sort of look swollen and puffy as opposed to that really nice bean shape that we often see. So let's look at what would be the manifestations for acute kidney injury. So first of all, important to recognize urinary changes. So changes in pattern. If somebody is at home and they come and they present with symptoms that would suggest changes in their urinary pattern, we need to pay attention to that. If someone is in the hospital, we're always monitoring their input and output, intake and output. Fluid volume excess, and that means that we're retaining more fluid than we're passing, right? So you're not, for some reason, we're not able to pass that urine, whether it's a cardiac output issue, whether it's an issue within our kidneys, whether it's an issue beyond our kidneys. So pre-renal, all kinds of reasons, intrarenal, post-renal. Metabolic acidosis, and that we talked about a little bit when we talked about DKA, diabetic ketoacidosis, just a second ago, When we move into a metabolic acidosis state, then our body wants to shift fluid so that we can actually compensate, and we, again, pass large amounts of urine. Sodium balance, the same thing. As our sodium balance changes the amount of urine that we are going to pass, and we can become profoundly dehydrated. Potassium excess, the same thing. Hematological disorders, all kinds of changes that occur in the cascade of clotting and other things can impact what's happening with our kidneys. If we have a change either by a drop in our calcium level or an increase in our phosphorus, again, we're going to have that fluid shift that's going to provide significant issues, and it will, because our kidneys are involved in this situation, in managing both our calcium and our phosphate, we're going to see significant symptoms associated with that. Because our kidneys are not functioning, and one of the big jobs of our kidneys is to be able to process certain kinds of waste. So different organs process waste for us. The kidneys play a major role in that. Because they're not able to process that waste, then we see an accumulation of that in our bloodstream, and we would see higher levels in our blood tests. And then ultimately neurological disorders. We've got that this alteration in our electrolytes. So we saw sodium balance changes because of AKI. Potassium rises because of AKI. And if you remember, elevated potassium is a critical condition. The biggest challenge for that is cardiac, right? Because it affects muscle contraction, and that big muscle that it's affecting is our heart. It causes that hematological disorders with that cascading clot. We see that it affects calcium and phosphate balances. So ultimately, all of that leads to neurological disorders, in particular when we look at some of those electrolytes. So there's three phases that we want to pay attention to with acute kidney injury: the initiation phase, the maintenance phase, and the recovery phase. So the initiation phase, it's characterized by an increase in that serum creatinine and BUN, and a decrease in the urine output. And those are classic signs. That's what we're always looking for. Elevation in serum creatinine and the blood urea nitrogen, or BUN, and a decrease in the urine output. In the maintenance phase, this lasts from a couple of days to a couple of weeks, even beyond, maybe even beyond a couple of weeks. And in this phase, because we've moved beyond just having a low urine output, we may actually see patients who have either a very scant amount of urine or no urine at all. Sometimes we also see patients who make a very, very dilute urine, and we call that nonoliguric, okay? Very, very dilute urine with a low specific gravity, and that's because all the those uremic toxins are not being removed. And this lasts anywhere from 10 to 14 days, can last a little bit longer, even several months. So the longer that phase lasts, that oliguric phase, the poorer the prognosis for recovery. And that's really an important indicator. So what we see in this phase, really important cardinal signs, would be that changes to our urinary output, those fluid and electrolyte abnormalities that we just talked about on the previous slide, and uremia. That's that accumulation of those uric salts, and the patient can become quite itchy. Their skin is quite itchy, and sometimes you see that that uremic frost. So we're going to have to watch for those. Watch that urine doesn't drop to less than 400 mils in 24 hours. And it's really important that we watch that there's vitamin D present for calcium absorption from the GI tract, because that's going to be another problem. And because only our functioning kidneys can activate that vitamin D. So when we have this kidney failure in our GI system, absorption of calcium decreases, and then when we have that hypocalcemia, because we're not able to absorb that calcium, our parathyroid gland secretes parathyroid hormone, and then that stimulates the bones to demineralize, right? So we get into this really difficult situation where we're leaching all the calcium from our bones in order to replace calcium that our GI system is not able to absorb because we don't have that activated vitamin D because our kidneys are not working. And phosphate as well. Phosphate is released, leading to that high level of phosphate that we just talked about. So low levels of calcium, high levels of phosphate. So finally, we have the recovery phase. And in the recovery phase, we see a return of the BUN and creatinine and even the glomerular filtration rate toward normal ranges. And patients can experience sometimes what's called a diuretic phase. And in that phase, we can see a lot of fluid and electrolyte abnormalities as their shifts happen. And we can actually, patients can actually start making a lot of urine. Begins with a gradual increase in urine from 1 to 3 liters a day. But at some point, it can reach 3 to 5 liters a day. So there's, quite significant amounts of urine that patients are making. And what's interesting in this phase is that although the patient's making a lot of urine, the nephrons are still not fully functional. And so that high urine volume causes this sort of osmotic diuresis. So as we have because the nephrons aren't fully functional, we have too much solute, and so we bring that solute brings fluid out with it, and so we can actually end up with massive fluid losses. So it's really important that we monitor our patients in this stage, the recovery stage, looking at their sodium, their potassium, and their fluid levels. So watch for hyponatremia, low levels of sodium, hypokalemia. Remember before we were talking about high levels of potassium, now we're looking for low levels of potassium. Remember, we're passing so much fluid with electrolytes in it, and also really watching for dehydration. Imagine if you're passing 3 to 5 liters of fluid a day. So this phase, do you remember that the maintenance phase lasts maybe 10 to 14 days, and sometimes even several weeks beyond that, right? It could even last a few months, but often 10 to 14 days. The recovery phase, again, lasts about 1 to 2 weeks, 1 to 3 weeks. And near the end of the phase, everything begins to normalize. And in particular, what we watch for is that acid-base balance to normalize, their electrolytes to come back into balance, and their BUN and creatinine to normalize. Now, it's important to recognize that while this can happen in the first, 1 to 2 or 1 to 3 weeks, as you move into that recovery phase, it can take up to a full year, 12 months, for a patient's kidney to fully stabilize. Important to recognize that we always want to make sure we take a urine specimen here. So urinalysis is really important. It's such a simple test and so important for diagnosis. We look at urine sediment, and we look to see what kind of cells are there, if there's casts or proteins there. We look at urine osmolality, and that's really important when we're looking at what a patient is passing within their urine. We can look at our urine for electrolytes, and we want to measure the sodium there and the specific gravity. To make a diagnosis of acute kidney injury, we have to do other tests most of the time, beginning with a renal ultrasound, so an ultrasound of our kidneys, and that's going to tell us about the anatomy and the functioning of our kidneys. But the advantage to an ultrasound, although it doesn't show us as much as some other more invasive tests, is that it doesn't require those nephrotoxic injections. Remember, we talked about some of those intravenous dyes causing further kidney injury. So the real benefit to that is that an ultrasound, although it's not perfect, it can be done even when we have elevated kidney function tests. A renal scan can assess renal blood flow and also look at the collecting system and really look at the integrity of that system. A CT scan as well can be really important. That can tell us if there's lesions or if there's masses when we're looking at intrarenal causes. It can also tell us where obstructions are occurring, if there are any. But again, we really want to watch that exposure to contrast, because that can be nephrotoxic and create a situation that is much more disastrous to our patients than what they have presented with. One of the most, just to wrap up and really bring this home, one of the most significant complications of acute kidney injury is hyperkalemia, and that is life-threatening because of the cardiac dysrhythmias that it's going to cause. And there's various therapies that we take part in to manage that. And if you look at table 49.4, it goes through that, but both insulin and salbutamol temporarily shift the potassium into the cells, and it shifts the potassium for about 6 hours. So when we give that insulin, as it carries glucose into the cell, it also drives potassium into the cell. And so it's really critical that we're understanding it's not getting it out of the body, it's bringing it into the cell temporarily. And then we can give other medications to be able to help us to pass that, to bind with the potassium and to actually help us to pass it. But it's really important that we watch for those dysrhythmias. A patient who has an elevated potassium needs to be on a cardiac monitor and have a 12-lead ECG. We need to make sure that if we are following those early treatments, so if we're giving insulin and potentially a medication called calcium gluconate, which again provides some protection for about half an hour against those dysrhythmias. The insulin can drive that potassium into the cell. We also give some D50 so that they don't have as a side effect of insulin a drop in blood sugar. So we would see that happen. But that's all just a temporary fix. We need an immediate temporary fix. And then we give a medication called Kayexalate or polystyrene sulfonate. And that is really critical because what that does is it binds with the excess potassium and we pass that. And it actually removes it from our body. And so the first quickest step is the insulin. And we're only going to do that if we have critically high potassium. Otherwise, if I had a potassium, let's say the upper limit, and again, the ranges at different hospitals. If my upper limit was, if I was at maybe 5.5 and my upper limit was 5.2, I probably would be looking at just the Kayexalate. If my potassium, and I'm not on dialysis, in which case, you know, you could remove the potassium. But if my potassium was 6 or 6.2, that's where you're looking at that rapid administration of D50 to bring up the blood sugar, insulin to drive the potassium into the cell where it's safe for the moment, because as that insulin is driving into the cell, the blood sugar drops. We've given that D50. We'll give calcium gluconate, which provides about a half an hour's protection against those dysrhythmias, just very short term. And then at the same time, we're going to give that Kayexalate so that that can actually bind with that excess potassium and take it out of the body. The most common indications for treatment for AKI include our volume overload, and that results in compromised cardiac or pulmonary status, or even both. Looking at elevated potassium levels, looking at metabolic acidosis, right? Our BUN level that's greater than about 43 millimoles per liter. Real significant changes in mental status. And when we have those cardiac complications like a pericarditis or a pericardial infusion or even a tamponade. Although it's important to recognize that lab values provide important parameters, the best guide, when we're looking at acute kidney injury, the best guide to treatment is good clinical judgment and constant assessment of your patient. Okay, another one bites the dust, acute kidney injury. And I will be back shortly as we move forward with our urology series.